Assalamu alaikum wa rahmatullahi wa barakatuh. Hello and welcome everyone. Nice to see you again in this year's webinars organized by the Emirates Clinical Nutrition Society. And my name is Ali Ashawa, clinical nutritionist and the scientific board member at the Emirates Clinical Nutrition Society. First of all, I would like to thank our sponsor, Nestle, for sponsoring this wonderful webinar about obesity. And I will be your host tonight, and I will be taking you through our webinar. First of all, I would like you to know that this webinar is being live streamed on MCI YouTube channel. And if you have any questions, please feel free to type it in the question and answer box and mention the speaker's name below. And if you have any questions, please feel free to contact the chat live support on the WhatsApp number seen in the screen in front of you. And two CMEs will be accredited by Dubai Health Authority after this webinar. And without further ado, let's start our webinar with our first speaker of the day, Ms. Ruba Al-Hourani, Senior Dietitian Head, Preventive Health and Nutrition Department in Ras Al Khaimah Hospital. Ms. Ruba is a health coach specialized in weight management, sports nutrition, endocrine disorders, bariatric surgery diets, and medical nutrition therapies for patients with cardiovascular diseases, hyperlipidemia, and digestive disorders. Ms. Ruba, thank you for joining us tonight, and I'm sure you will be having a wonderful speech from your side. The floor is all yours.
Thanks a lot for the nice introduction. Hopefully we can get to you and you get the feedback and the questions at the end of this presentation. So I'll just share my slides. Okay, so I'll be talking today about obesity and the application of nutrition to manage that. As we know, now we are in 2021, it has widely become and identified as a disease.
I'm sorry to interrupt, but we can't see you. If you can start the video.
It's already started. Let me just. Can you see me now?
It's not yet.
I can see myself.
Your video is started, but we can't see your face. It's a black background only.
Okay.
It's still the same.
I think it has been stopped by the host, so for some reason, I don't know.
It's fine, you can go on.
Okay. Okay, so you can see it now?
Yes, just
okay.
Screen. Thank you.
Okay, so we need to explain in the beginning, as I was saying, the importance and the prevalence of obesity, going through the diagnosis and assessment, complications, how to control and prevent obesity, and the strategies and the recommendations to further prevent any complications, and all sort of behavioral therapies. And as we know, overweight and obesity are defined as an abnormal and excessive body fat accumulation that presents a risk to health, and a body mass index of BMI, it is considered to be an overweight, and obesity is over around 30. And the issue has grown epidemic proportionally, with over 4 million people dying each year as a result of being overweight or obese in 2017, according to the global burden of the disease. The rates of obesity continue to grow in adults and children from 1975 to 2016, and the prevalence of overweight or obese children and adolescents aged between 5 and 19 has increased even fourfold, from 4% to 18% globally. And obesity is one side of the double burden of malnutrition. Today, more people are obese than underweight in every region except in South Africa and Asia. And once it's considered a problem only in high-income countries. Overweight and obesity are now dramatically on the rise, and in the low and middle income countries, particularly in the urban setting. Worldwide, obesity has tripled nearly since 1975. And in the 2016, more than 1.9 billion adults over the 18 years of old were yet overweight. And of these people, over 650 million were actually morbid obese. Around 39% of adults aged between the 18 were overweight in the 2016. And most of the world's population, they live in the countries where they are overweight and obesity. As the obesity, it kills more people than underweight people. Genetics and the etiology of the overweight and obesity is multifaceted, and genetics, they appear to play an important role in the development and the disposition of the adipose tissue. And yet it has been seen the problem to be as they overconsume energy, and there is less expenditure to that. Critical periods in obesity development, it includes fetal life, early in infancy, and then early childhood, puberty, and young adulthood, and pregnancy and menopause. The environment and the family and the society and the culture, they affect the development of the overweight and the obesity people. And people, they have problems with choosing the appropriate portion size. These, however, the concept should begin in the family environment. This, however, in an environment of many meals being eaten away from home, many people, they lack the knowledge to make good decisions. So this is the role where dietitians, they come. As current research, they indicates a defect in the fat metabolism for people who struggle, and they struggle with obesity. Intake and the expenditure may not fully explain the complexity of the weight regulations for patients who are obese. And obesity, it's becoming even more worse. So as we can see, current research, it indicates, as I said, furthermore complexity is happening worldwide. Now, how to assess and how to detect patients who is obese and overweight? We are using BMI. It is a simple index of weight for height, commonly used to classify the severity of being overweight. And according to WHO, for adults with BMI greater or equal to 25, they are overweight, and those above 30, they are obese, and greater than 35, they are morbid obese. And for children under the age of 5, overweight is, they are using charts, and according to WHO, overweight children, they have two standards, more than 2 standards deviation above the growth chart, WHO growth charts, and obese patients, they have 3 standards deviations above the growth charts. Children who are 5 years old to 19, reaching the young adults, the overweight, they have a BMI for age greater than 1 standard deviation for the growth reference medium, and obese, they have 2 standards deviations above the growth reference. And there are several ways to measure the fat and how it is distributed. We commonly use in the clinic the skin fold thickness tests in several parts of the body. We can use waist to hip comparison and other screening tests that includes ultrasound and CT scans and MRIs. Obesity can lead to more than simple weight gain. It can lead to severe complications and chronic diseases. Having a high ratios of body fat, it puts a strain on the bones as well and internal organs, and it can create or lead to inflammation in the body that puts the body as a risk factor for cancer. And it can, people with high body weight or they are obese, they can develop type 2 diabetes, arthritis, they can have breathing problems, infertility, elevated cholesterol, and even fatty livers and high blood pressure. Other issues that are related to being overweight or obese, it can put them into a very bad mood. They have some kind of feeling of shame and guilt and behavioral issues, social isolation, and lower achievements. So how can we advise such patients, and how can we control it? We can just focus on increasing their physical activity, encouraging them to increase their daily workouts from 150 to 300 gradually, and going from moderate intensity to higher intensity activities, and engaging them in different activities, and even socializing and asking like them to socialize and exercise with a group of people to encourage each other. They should be following a healthier eating plans that's focusing on lower calories that are nutrient dense, rich in fiber and whole grains, avoiding saturated fatty acids, and limiting the sweets and alcohol if they are consuming. Eating regular meals on regular intervals. They should know the hidden sources of sodium and sugar in the food. They need to be able to read the nutrition labels to identify what foods are helping them, and what foods, what kind of foods are increasing their calories. They should put an eye on their weight and make sure that they are maintaining specific weight. They are not increasing their weight significantly, or like they are not losing fast. And they should be consistent on sticking to a healthier options and healthier lifestyle. Now, who should consider a weight management intervention? Of course, a person with a BMI of 30 and above, or person with a BMI of 25 and 30 with other comorbidities. A patient with a high risk waist circumference, or with the 2 or more risk factors, like if they are hypertensive or diabetic as well. According to the NIH guidelines, it is recommended for obese patients to lose from 5 to 1 pound a week, and a person with a BMI above 35, person with a BMI above 35, they should be losing 1 to 2 pounds per week, and they should be allowing themselves around 6 months to achieve the 10% of the weight loss, not less, not more. And after 6 months, they should be focusing on the maintenance of the weight itself. A reduction of body weight and optimal rate of 1 to 2 1 to 2 pounds per week for the first 6 months and achieve an initial weight loss of up to 10% from the baseline. Of course, men, they tend to lose faster than women because they have a higher lean body mass and higher resting metabolic rate. And persons with a heavier mass or like higher BMI, they tend also to lose faster, although they are following the same amount of calories. And the modest of like the how it will affect the life. Of course, a minimum loss of around 4.5 kilo will improve and prevent the hypertension. 7% of weight loss, which is around 15 pounds, through the diet and exercise. It has been associated with a 58% reduction of diabetes, an average 7.7 pound loss, associated also with the reduction of overall other comorbid diseases. And it is recommended for hyperlipidemic patients to have a 10% of weight loss for those who are overweight, and those with other cardiovascular factors to lose more than equal to 2.25 kilo, to reduce around 40 to 50% of the intensity of the severity of the disease. Calorie restrictions and the weight loss improves insulin sensitivity, as we know, and other hormonal issues make a better control on the glycemic range, specifically in patients who are obese and diabetic. A 50% weight loss can decrease the fasting blood glucose, insulin, A1C concentration, and even the medication requirements. We need to ask and know if the patient is ready and they have the self-tendency to change. Otherwise, how often or how much we can help them. We need to know the background of the patient. If they have gone through any weight loss plan by their own, did they see another health perspective who actually referred them and who is encouraging them? Is there a specific reason? What is the level of stress for the patients? Does the individual have an eating disorder? Like, are they bulimic? Are they anorexic? Does the individual understand the requirements of the treatment? How important it is to lose weight? And how much the patient is willing to lose? And a combination of several strategies will only achieve a better outcome for the patient. It includes both diet, physical activity, behavioral therapy, pharmacotherapy, and surgeries if other strategies fails to compensate the weight loss plan. Starting with the diet therapy, it should start at least 6 months of time or until a weight loss goals have been achieved, with implementations of a weight maintenance program after that time. Greater frequency should be between the patients and the practitioner. They need to be easily accessible, and they have to be in a good relationships to ensure that they are having a successful weight loss and maintenance plan. An individualized reduced caloric diet is recommended for each different patient. It will be different. And reducing the importance of reducing dietary fat and carbohydrates, it's the most practical way to do that, with the creation of caloric deficit of 500 to 1,000 kilocalorie below the estimated energy needs, which will in turn result in a weight loss of 1 to 2 pounds per week minimum. Short-term studies showed that the nutrition education, such as reading the nutrition labels, recipe modification, and cooking classes, has increased the knowledge and may lead to improved food choices. The total caloric intake, it should be distributed, of course, throughout the day, not into 1 or 2 meals. It should be split into a minimum 4 to 5 meals and snacks during the day. Overconsumptions of energy at the end of the day will, specifically at the evening time, it's a negative effect on body. Portion control at meals and snacks, it results in reduced energy intake and weight loss. Substituting 1 or 2 daily meals with the snacks and meal replacement is successful when the patient fails to meet his caloric intake and following a proper meal plan. Meal replacement should not substitute a main meal as a routine. It should be supplementing the diet itself when there is less efficiency or less compliance to the plan. Along with the diet therapy, there should be a plan of physical activity, and it should be part of a comprehensive weight management program, minimum 30 minutes daily to 120 minutes of moderate intensity to high intensity exercise per week. And it should be started gradually for those who have been having sedentary lifestyle, as it contributes to weight loss and may decrease abdominal fat, and it also helps in the maintenance of the weight that has been lost. As per recommendations, adults should aim to 30 minutes of moderate intensive physical activity, preferably most of days of the weeks, as it increases the energy expenditure and play a very important role in weight maintenance. It reduces the risks for developing heart diseases, body fat, and it helps in the balancing the loss of lean body mass and reductions of resting metabolic rate caused by hypocaloric intake. And US dietary guidelines 2005 suggest 60 minutes moderate again activity on most days of the week to prevent the weight gain eventually that has been lost. And it also somehow affects the mood, and it relieves stress and depression. A combination with the behavioral therapy, it's very important, and should also maximize the use of multiple strategies, such as self-monitoring of the patient's stress, managing the stress, maybe by engaging them also with different courses, stimulating control, trying to understand the problem is and helping them to achieve or reach to the solution. Cognitive reconstructions and social support, it's very important to get the family, friends, environment, maybe at work also support. It makes a great impact on the total or overall weight loss journey, and it leads to maybe a better outcome and additional weight loss. When diet and exercise alone fails, and with multiple application and trials fail, then if the patients will need to, or it's recommended to supplement this plan. Usually some physicians, they advise into the use of some tablets, and it is only limited to those with BMI of 30 and above, or 27 with other risk factors, severe risk factors. And only FDA-approved weight loss medications may be part of that comprehensive weight management program, as research indicates that the pharmacotherapy may enhance weight loss in some overweight and obese adults. But it's very importantly to be aware that that's only advisable by the physician, and as he recommends, and need to be aware that some of the medications, definitely they will have side effects, so it will be limited to specific group of patients. If all the other strategies fail, then we can advise for surgical management. And it is again, it could be also categorized for patients with very severe or morbid obesity with a BMI above 40 or 35 and above, or as the physician advised, per the condition of the patient himself. And if only other weight management strategies, they fail to achieve this outcome. There is several and different types of surgeries, and it depends on the situation of the patient. After goes several consultations with the physicians, they will put on the proper plan for this patient. To sum up, we know that the weight loss and weight maintenance therapy should be based on comprehensive weight management program. It should not only focus on diet or physical activity alone. It should be a rather combination of several ways and strategies and therapies. And this only is more successful using them in combination rather than one intervention alone. These are my references, and I'll be happy to answer any questions if there is any.
Thank you very much, Ms. Ruba, for that very informative lecture. And we will be doing the questions and answers by the end of the session. Our next guest speaker for tonight is Dr. Khadija Mahmoud, Senior Specialist Registrar at Dubai Health Authority, in charge of Diabetes and Obesity Clinic in Hatta Hospital. She is a seasoned professional with 30 years of experience in clinical medicine. She has gained extensive experience in managing medical emergencies of cardiology, neurology, endocrinology, hematology, gastroenterology, and pulmonary. Thank you very much, Dr. Khadija, for joining us tonight. We are looking forward for your informative and rich lecture. The floor is all yours.
Yes. Assalamu alaikum and a very good evening to everybody. Are you able to hear me?
Loud and clear, yes. Go ahead.
Wow, that's great. Thank you so much, Dr. Alia, for the lovely introduction. And I would like to thank Raisa, who gave me this opportunity. It's such a pleasure to be in this webinar. Today, my topic is insulin resistance and obesity. As you all know, insulin has got multiple functions. It promotes certain activities while it suppresses unwanted activities like ketogenesis, lipolysis, and gluconeogenesis. The most important function of insulin is to facilitate the entry of glucose into the muscle, adipose tissue, and several other tissues. It also helps the liver to store glucose in the form of glycogen. It promotes the synthesis of fatty acids in the liver. And the most important is it inhibits the breakdown of fat. Insulin also acts upon the brain, and its main action is on the prefrontal cortex as well as the hypothalamus. Its main function on the brain is to regulate the food intake, the eating habits. Now, as you all know, you're all experts in nutrition. I don't have to tell what is hedonic food response. Actually, it is eating which is without hunger, just for sake of pleasure. So the regular eating, which we have every 3 times a day, our usual meals, is because we are hungry, we eat. But hedonic, we don't feel hungry, but still we just enjoy eating. Now, insulin helps to regulate these responses. Now, when insulin does not act normally, you'll find the restriction is gone, and the person who's got insulin resistance, he will start eating more and more. Now, when there is insulin resistance and insulin is not acting on the cells, you will find that the cells are dehydrated, they start shrinking, and literally the person starts craving for something sugary, whether it's a beverage or a food. Usually when we see patients coming with uncontrolled high blood sugars, they will give history that they've been drinking a lot of Pepsi because they were so thirsty. And as a result, you'll find they come with blood sugars above 500, 600 because they've been drinking a lot of sugary beverages. Now, insulin has got a very important function, which is a leptin-like function. And as you know, leptin is a hormone which reduces appetite. So when there's no insulin, this leptin-like action is also lost. Insulin also increases sex hormone levels, especially estrogen. And estrogen is known risk factor for obesity. A person is considered insulin resistant when the target organs do not respond to the normal action of insulin. Now, let me explain it by this picture. The first one over here, you can see the GLUT4 or the glucose transporter 4 allows the glucose to enter the cell. There are a series of enzymatic processes, and this results in the synthesis of protein, lipid, and glycogen. Now let us go to the lower picture. Here there's insulin resistance, and you find the GLUT4 is not allowing the glucose to enter the cell. So the insulin as well as the glucose starts accumulating in the blood. And an alternative pathway is stimulated. This pathway leads to nothing but inflammation and atherosclerosis. Now, to assess the insulin resistance, normally, it's not commonly done in our clinics, but for clinical purpose, what they use is known as HOMA, otherwise known as homeostasis model assessment. You've got online calculators, which everyone can use. You've got the IR HOMA and the Quick Eye. These two calculators use only two parameters, the fasting glucose and the fasting insulin. So you just have to feed these two parameters, the fasting glucose, the fasting insulin, and voila, you get your result. Any result which is above 2.5 is considered as insulin resistance. The problem is insulin resistance leads to obesity, and obesity leads to insulin resistance. So what we have to do is to control both so that we don't get into any trouble. When a person takes high-fat diet, you'll find that the cells get overloaded with lipids. There's a damage to the mitochondria, and a low-grade inflammation starts. This results in insulin resistance. There are various causes for insulin, but today we are going to concentrate only on something very interesting and very important: genetics, obesity, gut microbiome, and poor sleeping habits. The KBTBD2 is the specific gene for insulin sensitivity all over the body. So when there is a mutation in this particular gene, you'll find the insulin resistance is seen not only in the adipose tissue, but also in the liver and the muscle. Now, when there is a genetic background and you add environmental factors to it, like excessive eating or physical inactivity, you'll find that the patient starts gaining a lot of weight, he becomes obese, and this results in insulin resistance. And if there is a beta cell dysfunction, you'll find the patient develops type 2 diabetes as well. Now, the difference between insulin resistance syndrome and type 2 diabetes is just the beta cell dysfunction. Because when there is insulin resistance, the beta cells are functioning well. And the pancreas is not able to understand what is happening because it's pumping insulin again and again, and it finds that its insulin is not having any action at all on the cells. So it keeps on pumping more and more. As a result, the beta cell mass itself becomes bigger. But after some time, when the sugar starts rising, then the pancreas starts getting exhausted. So what happens is gradually the cells start dying and beta cell dysfunction sets in. That is when you develop type 2 diabetes. The problem is both these diseases, both insulin resistance syndrome as well as type 2 diabetes, have common complications. Hypertension, obesity, dyslipidemias in the form of high triglycerides, high LDL, low HDL, and most important is the hypercoagulability. So what is the danger? The danger is endothelial dysfunction and atherosclerosis. So when a person has got metabolic syndrome or insulin resistance syndrome and type 2 diabetes, with all the common complications which they have, you'll find the patient lands up with cardiovascular disease. And this is what we are trying to prevent. That is why we tell our patients, please control your diet, please do exercise, because we want to prevent complications. Now let us take obesity. Obesity, as you all know, is expansion of fat mass. But how does it expand? There are two ways it does. First of all, the fat cell can increase in size, that is known as hypertrophy, or there can be increase in the number of fat cells, and that is called hyperplasia. Now, when the cell becomes hypertrophic, it doesn't remain a normal fat cell anymore. It becomes a pro-inflammatory cells producing cytokines and inflammatory chemokines. So as a result, the patient develops insulin resistance. Moreover, the hypertrophic fat cells have less number of GLUT4. So it's a GLUT4 which is essential for allowing the glucose to enter the cell. So when there are fewer GLUT4, there's lesser chances of the glucose entering the cell. Here you can see when there's overnutrition, the adipocyte increases in number, and that is called hyperplasia. And when there's chronic overnutrition, you'll find the cells themselves become huge and hypertrophic. And there's so much fat available that they get deposited in the ectopic areas, that is the liver as well as the muscle. Moreover, chronic inflammation starts happening. Now, let's look at the healthy fat cell. When there's a healthy expansion, you'll find there is adipogenesis, the volume is normal, and insulin sensitivity is high. And very little inflammation is seen in these cells. But when the cells become hypertrophic, they become really abnormal, dysfunctional, and they attract a lot of macrophages which get deposited in these fat tissue. And here the adipogenesis starts coming down, and insulin sensitivity also comes down, and a low-grade inflammation starts. So all these lead to different complications. Let us see the dysfunctional adipose tissue. You can see how it is producing adipokines, all toxic ones, and they act upon the vasculature, and there's a defective insulin signaling, so there's atherosclerosis, impaired glucose uptake in the skeletal muscle, and in the liver, you'll find this excessive production of glucose, which is gluconeogenesis, and excessive release of triglycerides and dyslipidemia. And all these things would result in different complications like stroke, myocardial infarction, and peripheral arterial disease. And as our previous speaker mentioned, so many other complications like cancer as well. Now let us see what is a macrophage. A macrophage is just a simple white cell. Its duty is to engulf any foreign particle which enters the body. Normally, the lean fat, in the lean state, we do have macrophages, but they're beneficial ones. They're not going to harm us. But in the obese state, they increase in number by 14 to 30%. And the normal macrophage becomes a pro-inflammatory macrophage producing cytokines and chemokines. Now, this is a beautiful picture of a macrophage of a mouse model, and you can see how it is stretching itself to catch those two tiny particles which are foreign. So it has got a beautiful function. Let us see the macrophage in the lean state and in the obese state. In the lean state, there are few macrophages which are resident to the adipose tissue, and they produce interleukin-10. Now, interleukin-10 is an anti-inflammatory cytokine. But when the person starts eating a lot and does not do any exercise, it starts gaining weight, as I mentioned earlier, the fat cells become hypertrophic, they increase in number, and they attract a lot of macrophages. And these produce pro-inflammatory cytokines like tumor necrosis alpha, interleukin-6, and this will lead to insulin resistance. Let us see the effect of sleep restriction on insulin resistance. Whenever the person has disturbed sleep, and maybe due to stress or whatever reason it is, and he's not sleeping well, you'll find there's an activation of the orexigenic system. Orexin actually is a neuropeptide. It increases the craving for food. So when it is stimulated, all the hormones and neuropeptides, the peptides, which are essential for maintaining a good body weight, like leptin, ghrelin, GLP-1, all of them, they go haywire. Goes up and down. Leptin, which inhibits hunger, becomes low. Ghrelin, which stimulates hunger, becomes high. GLP-1, which increases satiation, also becomes low. So everything is upside down. And moreover, there's an increased activity in the food reward system. So the patient is hungry and he keeps eating. There's a small increase in energy expenditure, but that's not enough because there's a positive energy balance which increases the body weight. This results in obesity, and in turn, it causes insulin resistance. Now, today's most important topic is the gut microbiome. In humans, will you believe it or not, there are more than 100 trillion microbial cells in the gastrointestinal tract. Millions and trillions. Now, these are collectively known as microbiota. They can be bacteria, they can be fungi, they can be viruses, and they actually live in harmony with us. It's a symbiosis. We don't harm them and they don't harm us. It's actually gained when the fetus is in the mother's womb, where through the placenta it gains some bacteria. And when the child is delivered, if it's a vaginal delivery, it gains some bacteria from the vagina, from the skin of the mother. If it is a cesarean section, it gains all the bacteria from the hospital and from the skin of the mother, skin of the nurses. So the human being acquires a lot of organisms and they live happily in the GI tract. They are very important for us because it helps in pathogen protection, nutrition, in the metabolism, and also in the immune response. So it's very important. Moreover, the microbiomes also synthesize very important vitamins like vitamin K, B12, biotin, folic acid, etc. But the microbiomes can also contribute to obesity when there's an increase in the lipoprotein lipase activity, increased intestinal permeability, and lipogenesis. Now, how is that? With trillions of organisms, we are not having any disease. This is because there is a balance between the beneficial ones and the harmful ones. So the main organisms which are present in the body are the beneficial ones. And the other commensals are all kept under control because there's a balance. And we should not disturb them, because if we disturb them by taking the wrong diet or by abusing antibiotics, we're going to cause an imbalance. And this will result in metabolic disorders, especially obesity. You can see in a balanced gut microbiota, you'll find the beneficial commensals are happily sitting, they're high in number, while the harmful ones are sitting quietly there because they're very few. So There is less gut permeability, less sepsis, less inflammation, but increased insulin sensitivity. And so we are metabolically and cardiovascularly healthy. Now, if we start eating high-fat, high-sugar diets, don't do any exercise, and use antibiotic for no rhyme or reason, we upset the whole balance. There'll be an increase in the harmful opportunistic organisms and a decrease in the beneficial ones. This results in increased gut permeability, toxemia, inflammation, and increased insulin resistance. So as a result, we develop metabolic disorders like obesity, type 2 diabetes, fatty liver, etc. So the wrong diet, there's a dysbiosis of gut microbiota, and there is changes like chronic inflammation, energy harvest, and you get obesity and other metabolic disorders. As you can see, the obese person has got reduction in the bacteroidetes, which is supposed to be at a higher level, and increase in firmicutes, which is supposed to be on a lower level. But the best part is it's reversible. If you lose weight and if you follow a proper diet, you can completely normalize the microbiota. That is the best part of it. Now let us see an altered gut microbiota, what it does. It'll increase the gut permeability and make some changes in the gut wall. And this will result in increased lipogenesis, increased fat storage, cytokine release causing inflammation. And as a result, the patient becomes obese and insulin resistance, the usual metabolic problems. But they found that when you give a prebiotic or a probiotic, which can bring the microbiota back to normal, that is, restore their balance, then all these activities which you found during altered balance is completely cut off. And what happens is an increase in the peptides which actually help the metabolism. So there'll be an increase in the peptide YY, in the GLP-1 and ghrelin. And these hormones, as you all know, increases satiety, reduces energy intake, and reduces the body weight. So the main component of insulin resistance or a metabolic syndrome is visceral obesity, insulin resistance, hypertension, impaired glucose tolerance, high triglycerides, and low HDL. So what you see, if you see it clinically, you'll find the patient's got central obesity, and there'll be features in females of polycystic ovary syndrome, and you'll find the blood pressure is high. And apart from the dyslipidemias, you'll also find the uric acid levels are high. So these are some of the pictures of what you'll find in an obese person with insulin resistance. Acanthosis nigricans, as you can see, is a black velvety skin lesion which is found in the nape of the neck. And the facial hair and acne is found in the polycystic ovary syndrome. Central obesity is a classic feature which you'll find. And along with that, you'll find the patient's blood pressure is high, sugar is high, and lipid abnormalities will also be seen. Treatment, I'm sure all of you know what to do. Main thing is weight reduction, exercise, and dietary modifications. I will not mention a word about dietary modifications because you're all experts. I'm not an expert in that, but I can talk about pharmacological treatment and surgical treatment. Now, when a person does exercise, the effect on insulin resistance is because of the increased oxidative enzymes, increase in GLUT4, which is, as I mentioned, is reduced in adipose, adipocytes when they are obese. There's increased capillarity and reduced central obesity, adiposity. So exercise has a lot of effects. Now let us see, it's a beautiful picture of insulin sensitive and insulin resistant patient and the effect of exercise. Now, the first picture you can see, when the person is insulin sensitive, the glucose gets stored. in the liver and in the muscle as glycogen. If there is overnutrition, increased high carbohydrate diet, you'll find that the glycogen is no longer stored in these places. And there is lipolysis and release of triglycerides into the circulation. Now, if an insulin-resistant person does some exercise, you'll find the reverse. There's less release of triglyceride from the liver and more glycogen storage, both in the liver as well as the muscle. And if you noticed it, it is after a single bout of exercise. Imagine if you do the exercise regularly, how wonderful it's going to be. Now, I think you people know more about prebiotics and probiotics. Prebiotics are food that promote the growth of beneficial gut bacteria, while probiotics are edible sources that contain health-promoting microbes like lactobacillus. Now, inulin is a type of prebiotic fiber, and they found that when it's given to an obese person, it increases satiety. And the mechanism by which it increases satiety is by increasing the fermentation, and also it increases the levels of GLP-1 and peptide YY. And these hormones are known to increase satiety, reduce the energy balance, and reduce the weight. Pharmacological therapy, TZDs are very famous. They're excellent drugs for reducing the insulin resistance, but the problem is weight gain because they do cause fluid retention and edema. So the patient does gain weight, although the insulin resistance goes down and the sugars come under control. Metformin is commonly used. Apart from the gastrointestinal side effects like bloating, some people have diarrhea and discomfort. Otherwise, it's quite well tolerated. The other treatments which are used are not commonly, we use it commonly in our clinics. Now, if the patient is morbidly obese, I mean, it is not easy for the patient. We can teach her lifestyle changes, but it is not easy for them to move around and they need help. I think in selected patients like that, I think we should go for bariatric surgery. And of course, lifestyle changes is a must. There's no doubt about that. But these patients do need help. So bariatric surgery will help these patients. Now, the most important is, ladies and gentlemen, is to reduce chronic stress, because stress leads to sleep disorders, and sleep disorders will cause increase in weight. And have a good night's sleep, please. If you exercise, I think you'll have a good night's sleep. And the most important tip is to keep moving. Get NEAT. NEAT is the non-exercise activity thermogenesis. How do you do it? Simple activities. You don't have to go to the gym every day. Some of us are so busy, we have no time to go to the gym. But let us do something simple. For example, let us wash the dishes by hand instead of putting it in the dishwasher. Let us keep walking while we're talking on the phone. All of us are on the phone all the time. But if you can keep walking, moving all the time, and then talking, you save your time and do the exercise as well. If you have some errand in your office, please don't send a text, email rather. Go to that room and convey your message. If you have a car, park it far away from your house and walk back to your house. I mean, these are simple things which all of us can do. You don't have to go to the gym every day. It's not at all practical, believe me. So, ladies and gentlemen, the take-home messages: eat healthy, keep moving, and avoid insulin resistance. Thank you.
Thank you very much, Doctor, for that wonderful presentation and talk. Our next speaker for tonight is Dr. Al-Haj, Senior Clinical Psychologist at Dubai Hospital, DHA. Her areas of interest include adjusting to chronic and terminal illnesses, adherence to medical and lifestyle regimens, communication in medical settings, provision of psychological care to patients and families, and training multidisciplinary teams on the psychological aspects of health, illness, and illness management. Thank you very much, Dr. Najat, for joining us tonight. We are very excited for your talk. The floor is all yours.
Thank you, Alia. Good evening, everyone. Assalamu alaikum. Can you hear me? Hello. You cannot hear me.
We can hear you, yes. Can you share your PowerPoint?
Yes. Can you see my screen now?
Just full screen mode and you're off to go.
Okay, just, all right. You can see it now in show mode, right? Okay. Well, I just wanted to thank you again, Alia, for the lovely introduction. And thank you to ECNS for the invitation. My wonderful colleague, Ms. Afra from Dubai Hospital. It's also wonderful to be working with MCI, with Zaid and Cheryl. And it's lovely to see again Dr. Khadija, my dear colleague. We worked together in previous events, and to meet Ruba today for the first time. And I look forward to Nicole's presentation. What I wanted to talk to you about today, of course, you have all this vast information about choices that patients can make in order to improve their health. So I'm going to be talking about the psychological aspect of intervening with patients. How can we influence a patient who comes to our office? Maybe for us, it's a little bit longer, but I know for you, it might be a little bit shorter, who comes for 15 or 20 minutes every 3 months or every 6 months. Obviously, the emphasis in my talk would be on how to facilitate change, because we know that we live in an era where disease, a lot of it is chronic and has to do with lifestyle and lifestyle choices that people make. And lifestyles are complex and they are impacted by so many factors. It's not just the patient's choice or contribution. So I'm going to talk in more detail as we go, and I hope I keep to the time. Okay, so first of all, I'd like to just kind of talk a little bit about weight management, what it is. We know that it's chronic, so it's a lifelong to a lot of our patients issue that they have to manage, and it's very complex. And just listening to Ruba and to Dr. Khadija, there's so much that goes into maintaining a healthy weight. Sorry. It requires the initiation and maintenance of multiple behaviors at the same time. So obviously we have to consider each individual patient, their capabilities and their knowledge, and basically what it takes to introduce changes. And I will talk some more about these. And most of all, it requires effective patient-provider communication and relationship. Communication is the vehicle, the bridge by which we share knowledge with our patients. And I like to use the word exchange information because we want to listen to this patient as well, as opposed to basically just telling them what they need to do, because that does not work. And we know that. So a more collaborative method of intervening is now proven to be more effective. than a prescriptive model, which is I'm the expert, I'm going to tell you what you need to do, you go home and you apply. That doesn't work anymore. So understanding change. You get a patient in your office, and in order to be in a healthier state, they have to introduce, implement, and sustain some changes, whether to their diet or lifestyle by way of more exercise, and or maybe take medications on time, and all of these things. So change is not an event. It's a process that takes time, and it's a very complex phenomenon. First of all, you really want to know how ready for change your patient is. We can't use a one-size-fits-all model. So you get a patient who you want to work with on maintaining a healthy diet and losing some weight, and you basically say the same thing to all of these patients. The science, maybe the principles do not change as much, but the way you intervene with the patient should suit each individual patient. And usually the example that I give is you go to a tailor and you basically tell them, give them a design to design this wonderful garment for you. And they do an amazing job, and it looks flawless and it's perfect, but it's not your size. That garment is going to be useless. So unless the intervention matches this individual patient, it's not going to be as effective. You will have patients who will just leave that advice right at your office, and they won't apply it because they don't feel this is going to work for them for one reason or another. So we match the intervention to the person's level of readiness. And I'm going to share with you one of the models of change, which is the trans-theoretical model of change. There are so many different models, but this one in particular illustrates nicely that the stages of change as a patient goes through them. So stage one is pre-contemplation, which is this patient is not even thinking about any changes. They feel that they are okay. They don't need, they have no interest or need to make any changes. Second stage is contemplation, which is thinking about changing, but they're not taking any action. Maybe I need to cut down on sugar a little bit, or maybe I shouldn't drink as much soda, Pepsi, or eat as much chocolate anymore, or maybe I should take walks every now and then, but they are not doing anything yet. Preparation is basically they have thought about it, and now they are working on making some changes. So maybe they are checking out gyms in their area, or maybe they are driving around to see if there's a good, nice walking path near their home, or maybe they are asking friends if anyone wants to partner with them. And then action is basically doing it, whether it's improving their diet, or doing some physical activity, or starting to become more compliant with the medication, and so on and so forth. And then maintenance would be maintaining that change and preserving the benefits that they acquired. One important issue here to keep in mind is that these stages, this model, these are not linear. So someone can be here in the preparation stage, and then they just kind of go back to contemplation, or they go back to indifference. They're not thinking about it anymore. So it's not necessarily linear. But what is important is for you to figure out where your patient is right here. Okay, because if they are in stage one, it makes no sense to start with them in 4, which is action. They're not even thinking about it. So you have to meet them right here at 1 and just kind of walk with them through the sequence of stages here. So what is research telling us about the psychological predictors of successful behavior change? What do people who introduce behavior change and sustain it, what do they have? So for increased people who are successful in maintaining increased physical activity and having positive weight outcomes have shown to have self-efficacy. Self-efficacy is extremely important, which is our confidence that we can execute a course of action. Okay, so, okay, I need to cut down on sugar. I think I have what it takes. I think I can do this. Okay, and then they kind of embark on this new behavior. Or I think I can take a 10-minute walk every day or every other day. This is something that I think I will succeed at doing. So a sense of self-efficacy is basically your confidence. I'm going to talk about that some more later. People who are successful in behavior change tend to have autonomous motivation. And basically, it's wanting to do it from inside, not just because somebody else told them. And this has very important implications that I will talk about. So they self-endorse. So this change they believe in, not because my doctor told me or my dietitian told me or my psychologist told me. I believe I should be doing this for my own good. So an internal motivation is extremely important here. And then the use of self-regulation skills. People who do have those self-regulation skills are more successful than people who don't have these skills. And these self-regulation skills include monitoring their weight, okay, monitoring their dietary intake, keeping an eye on their physical activity, and those who can set some goals, and then maybe planning. And these can be very simple skills. Sometimes you have a patient who tells you, I work with bariatric patients on planning for their surgery and then on behavior modification after surgery. Sometimes I ask patients, do you think you have time? How much time do you have per day to exercise? And sometimes they tell me, oh, I have no time at all. You know, I have this job and then I'm doing this on the side and then I have this and I have that. And then we sit down and we just kind of break down their day. And it turns out that there is time, but it's just kind of planning. It's being economical about using their time. And I tell my patients all the time, I challenge them that nobody can tell me that they don't have half an hour per day to take a walk. So goal setting and planning techniques, as simple as they may sound to you when it comes to taking a walk, but these can be complex. And sometimes people plan things at the wrong time. And then they can't do it. And then they kind of give up and become frustrated. So it's very important to kind of have these skills. Long-term weight control, people who succeed at this were shown in research as having flexible eating control. So no particular behavior is forbidden. They have flexibility, which is, to me, this is an indication of mature level of knowledge. So they understand food intake, they understand energy balance, so energy coming in, energy being used, they understand that and they are able to balance. Flexible eating also means the patient has some control. And as humans and even some animals, in some studies, we like to have some control. And sometimes people may not necessarily mind making some changes to their dietary habits, but the loss of control can be frustrating and can make people go back and regress, basically. More gradual understanding is always better than just a huge dose of information. And I always tell my patients, you just keep educating yourself, and it becomes more manageable as you go. Research also tells us that people who have positive self-image tend to do better. Okay, so when I see a patient who's really, really, really struggling with their self-image, then I need to pay more attention to this because it can be an obstacle. So these were some of the traits that the research is associating with success in behavior change. So what does this mean when we intervene with our patients as we see them in the office? So the essentials of enduring behavior and lifestyle changes, these are the most important things that each patient has to have before they can aspire for success. Knowledge and education, this is number one. So usually when I see a patient, for example, a diabetic patient that is sent to me because of non-compliance. So A1C is 12 or 13 or 9 or 10. The first thing that I do assess, and I basically ask them basic questions, but then I send them back to the experts for the education if there is informational gaps and informational needs. So knowledge and education about diet, about physical activity, about the science of eating and burning energy, that's the foundation. But knowledge is not, it's necessary. Without it, there's no lifestyle changes that are successful because you have to have the information, but it's not sufficient. You can find someone who is extremely knowledgeable, even a physician who has all the information, but they are not making any changes to their lifestyle. Then motivation, how motivated this patient is. Maybe they have the knowledge, but they don't have the motivation. And in this case, the knowledge sits idle. It's not helping them. Okay, so how motivated are they? Maybe they have the knowledge, they have the motivation, they really want to make a change, but there is no self-confidence. Okay, so we need to empower patient, and there are techniques for that. So the patient feels confident. If I start this, I'm going to succeed. And even if I face some issues, there's help and I can reach out for help. So knowledge is the foundation. Motivation is extremely important. Self-efficacy has to be there. And usually I ask patients about their trials, what they did in the past and how their experiences were like. Sometimes patients have had experiences maybe that have nothing to do with their health, but they failed, or they perceive that they failed at certain things. And they have this sense, I'm going to fail at this too, so I'm not going to try. So self-efficacy is important. Skill development. How do you plan to to plan the change and then to implement it and then to sustain it? Okay, so they have to have that skill set that allows them to set goals. You don't want to set a goal that is so unattainable. It's a huge goal. You fail at it, or you don't do it the way you want to, and then you are discouraged and you stop. And we see a lot of people who do start some change of some sort, and then they basically stop at some point. And then barriers. It's extremely important that our patients have some insight about barriers that they encounter. Sometimes I get some patients who are really perceptive. I had a patient once tell me that the environment, this patient told me specifically this, he said, the environment that I live in and the environment that I work in, neither one encourages healthy eating. So he said he's just surrounded by all this unhealthy food all the time, friends, family, co-workers. And he said, this is one of my issues. And it's really wonderful to just have that identified and to kind of work on that. And then support. And I think Ruba talked about support. Social support is extremely important. And, you know, sometimes I see patients and I ask them to bring a family member with them to some of their appointments, because you want them to have the same information that you have. Or why don't you go and research online together? Because you want people around you, at least some of them, to be on the same page so that they can support you. Sometimes I get family members for things other than lifestyle changes who come to me and ask me, how can I help my husband or wife or friend or sister? And support is extremely important, and it's documented in research. So let's talk a little bit about barriers. I'm trying to keep an eye on time here. So patients' capabilities can be an issue, which is lack of knowledge. If a patient does not have the knowledge base, then they really need to see the experts right away. And I tell patients, those especially educated patients who have access to information, do not rely just on the experts. You don't want to go to experts asking ABC. You want to educate yourself, and then you go to them with more advanced questions. So lack of knowledge or lack of skills necessary to implement changes. I once had a patient who was a bariatric surgery candidate, and we talked about lifestyle changes, and he talked about exercise. And what he decided to do, him and his wife, he said, they go to pray Al-Fajr prayer at a mosque that is 18 villas from his home. He counted them. And he said it takes about 20 minutes to get to the mosque, pray, and come back. And he said for years, him and his wife would go every morning to pray there. And he decided to put, because he's such a busy person, to put link his exercise with prayer. So what they decided, him and his wife would no longer drive to the mosque. They would just walk 20 minutes, do their prayer, and come back walking again 20 minutes. And he said, this is my exercise. By the time his day starts, he's done with his exercise. So I think this is a good way of managing it, because he linked it with something that he does every single day at a time when there is very few interruptions. But not every patient can be as skilled as this patient. So the intention, motivation, again, health beliefs. Does this patient believe that his behavior, when he makes those changes, will have a positive impact on his or her health? Because sometimes you get people who will tell you, oh, these are just my genes. There's nothing I can do. So you want to examine the patient's health beliefs. Psychological, psychosocial, if there's any stress, anxiety, and depression. I've worked many years ago with patients on just the basics of life before we talk about psychological interventions or parenting skills or time management, stress management. So stress can be a huge obstacle because people become less motivated, become in a state of mind that's not conducive to working on themselves. Anxiety and depression, we do a screener on all of our, for example, bariatric patients as well, or the patients that I work with on non-compliance. Social influence, and again, this is the impact of the environment around us. We cannot ignore that. We cannot work with the patient as if they live in one island by themselves, or as if they have 100% control over their environment. They don't. Most of us don't. Priority setting, affordability. Okay, so healthy food, we know that is more expensive. So affordability can be an issue as well. So provider counseling, of course, and we all do that one way or another, and shared decision making. This is extremely important because I talked about a collaborative model for intervening with patients in basically everything that we do. Before, models that were available were designed to treat acute illness. So somebody comes with a pneumonia or TB or some acute illness, and there's a quick protocol for treating that. And now we are dealing with more chronic diseases that are impacted by lifestyle. So the patient sees us for a little while, and then they go home, and we expect them to implement what they receive information about in the office. Less the patient, we treat them and perceive them and allow them to be partners in this partnership. We cannot expect a whole lot of change. So it's really important that we listen to our patient. It's really important that we ask, what can you do? Okay, so if I see a patient who's referred to me, again, for uncontrolled diabetes, and I basically tell them what they have been told for a few years now, this has not worked, obviously. For a patient who's has a high HbA1c. So there's no point in repeating the same information to them. And now we know that information alone is not gonna work. So I want to listen to them. I want them to tell me what they have tried before. I want them to tell me who's around them, who can influence them positively. I want them to tell me what they can do. Sometimes I negotiate with patients. I had a patient before with uncontrolled diabetes. And basically I asked her, how many times do you check your glucose level? And she said, I don't, because I just don't want to see bad numbers. And dietary habits, just whatever. So testing was an issue. And we agreed at the end of the day. I asked her, so how many times do you think you can test? And she said, once a week. And of course, this is horrible, but I had to take that. So I'm like, okay, we have a start. So it makes no sense for me to be right here and she's right here, and I expect her, just because I talked to her, to come all the way and meet me here. So I have to come, and basically we just kind of walk back together. So when a patient is a decision maker in the process, they are more likely to commit than when we tell them what to do. And I often tell my patients that, yes, I am an expert in my area, but you are an expert about yourself and about your circumstances and about your environment and about your challenges. And unless we put your knowledge on the table together with my knowledge, we cannot come up with something that will work for you. So basically, the patient is equal to me. They are expert in one area, I'm an expert in another area. And also at the same time, you give the patient control in the situation, okay? So shared decision-making, and this is not my opinion, I agree with it, shared decision-making now is accepted as established in the literature as more effective than just telling the patient what they should do. Okay, so strategies for that support medical adherence. I'm gonna skip this. This is a little bit, okay, strategies that support lifestyle changes. There's a saying, maybe it sounds like a cliche, but it does work. You kind of dream big and you start small. So you want to agree with the patient on 1 or 2 appropriate goals, okay? Which is basically breaking down a big job, complex job, into smaller, more manageable chunks, just like you would do with your kid. We like that as humans, you know. If I want to reorganize my kitchen and just kind of really work on it and make it, you know, new and clean and all of that, usually I just start one cabinet at a time. Okay, otherwise I'm going to find that like this is really overwhelming. It's just a lot of work. The same thing you might be using with your child. So if they have homework, they have 5 or 10 or 15 pages, you start 1 page at a time. So we get this done, yay, that's fantastic. Let's move on to the next one. Okay, so you start with 1 or 2 appropriate goals. And these are the behaviors, again, listening to the patient, that the patient feels ready to change. I don't choose them for them. So I tell them, what do you think you can start with? And they might say, well, I think I can start with giving up or drinking less Pepsi, for example. Or instead of eating 10 little chocolates per day, and maybe I'll do 4 or 3, just whatever. And I take it like, okay, we have a deal. Let's start there. So behaviors that the patient feels ready to change. And usually they choose easy ones, which is very good, no problem. Because when you do those easy ones, they're easy to do, and you get a sense of achievement. And that sense of achievement is an invitation to motivation. We don't sit down waiting for motivation to come to us. It needs some invitation. And getting a small achievement is that one. And then develop specific goals. Things have to be clear. And we all know about SMART goals. They have to be specific. Okay. So this patient said she will test once a week. Okay, that's really clear. Let's start with that. Create a self-monitoring plan. Okay, so dietary intake, physical activity, and the simpler, the better. Okay. And then for the clinician to monitor and follow up and refer for additional assistance. If you feel this patient, for example, is really stressed out, refer them to psychology. Okay, if you feel they need information about insulin, how to take their insulin administration or dose correction or anything like that, you just refer them. If you feel they need any kind of service within the system, then because the more comprehensive the intervention, the better. Okay. Improve patient-provider communication. And I've done so many sessions on communication. I can talk forever about this, but communication is really, really important. And poor communication is the culprit in a lot of unfavorable outcomes. Communication is never one way. So we really have to have time to listen to our patient. The first time I meet a patient, I'm not talking as much. I want them to tell me their story. And sometimes they ask me, where do you want me to start? And I tell them, just start whatever you want. I'm just going to organize it here in my head. You just go ahead. So we have to listen to our patient, because remember, we want to tailor this intervention to fit them. And unless we get their measurement, this garment is not going to fit, okay? And the measurements here is the patient's knowledge about themselves, about their past history of trying to introduce changes, their environment, their sense of self-efficacy, what they think of their abilities and skills and, and everything. Utilize the power of listening. And this is basically another way of saying that communication, good communication, effective communication is never one way, ever. It has to be going in both directions. So you want to listen to your patient. And what I mentioned before in a different setting, you want to get to know your patient. because every patient is unique. And unless your patient tells you their story, unless you figure out their unique challenges and obstacles, you cannot intervene, okay? Because now we know that non-compliance or failure at introducing lifestyle changes, there's a barrier, maybe one or two or more, that are affecting this patient's attempts. You know, sometimes you see patients who will tell you, oh, I've tried everything and it doesn't work, okay? And you want to know more about that. Demonstrate empathy, and empathy is so important. Sometimes it's easy to judge a patient. You have everything, you have this expert and you have that expert, and we've told you this so many times, and yet you are not doing it. It's kind of easy to get to that mindset, but that's not helpful. So we have to demonstrate empathy when a patient comes to us and, you know, they wanted to try something and they didn't try it, or they tried it for a little bit and then they stopped, and just to acknowledge at least that they have attempted, or to acknowledge at least they made it to the appointment. Okay, this is really wonderful. You know, you have taken a step, and let's take it even further. Remember that sometimes, you know, these patients come to you with a history of past failures, or with history of poor treatment by others, or with history of some really sad personal stories. So you don't want to be one more person to basically beat them down. You want to be that inspiring figure in their life. So demonstrating empathy is extremely important, and it goes a long way. Sometimes a patient might not remember much of what you told them, but they do remember the demeanor and the way you receive them and you talk to them. Elicit patient questions. Sometimes we are so busy, and sometimes physicians are so busy, they have a lot of people outside waiting for them to be seen. But it's extremely important to ask patients, do you have any questions? Explain who is who in the team. Sometimes it's easy to figure out, sometimes it's not, and we don't want to assume. We have some patients who are really savvy, they know the different systems, and we have patients who are not. And it's really important that we explain the role of the team members and how they can help the patient. Sometimes I get patients who tell me, well, all these people come in and out my room if they're inpatients, and I don't even know who they are. I don't know which kind of doctors or nurses or healthcare providers. They just don't know who's who. Sometimes they tell me, all these doctors, they talk to each other about me, but nobody talks to me. So we really need to kind of be careful when it comes to the patient, and we want to orient them and educate them about the team. Facilitate easy access to provider, where they can get a hold of you. How can they ask you a question? Do they have to wait 3 months before they can come back to you? Easy access is really important, and it's another way to support our patient. Sometimes there are some patients that I ask them to just kind of stop by for 5 minutes because I want to check with them on something. And by facilitating easy access and by monitoring, the patient knows that you are with them. They don't just see you once every 3 months and then you disappear. Okay, so by you being in the picture one way or another, that could be a motivator for them. Okay, so the bottom line is behavior change is rarely a single event. It's not. The process of change is often gradual and non-linear. So it's okay if your patient falls off the wagon. Okay, we can help them get back up again. No judgment. Okay, and sometimes I tell my patients, you know, if you encounter any issues, any difficulties, just come back and talk to me. I'm not going to judge you. We're just going to focus on what to do, problem solving. Patients fall along varying levels of readiness for change. So we want to know where this patient is on the change continuum or the stages. Patient education is necessary, but it's not sufficient to trigger, promote, or sustain behavior change. So we really have to move past this provision of information, go do this and come back in 3 months. That doesn't work. Okay, information is necessary, it's important, but we have to look at the other areas that can impact this change. Healthcare providers, this is really important, are slowly transitioning from the traditional role of the knower. I'm the expert, I know my area, I'm going to tell you what to do, and you go do it. Now we are more facilitators or coaches, okay? Because at the end of the day, the patient with chronic disease and lifestyle issues, the patient is in the driver's seat. So we want them educated, motivated, empowered, and to buy the idea so that they apply it and to be part of the decision-making. Understanding the process of change, as well as behavior modification theories and techniques, I really encourage all of you to just kind of look at at least the principles of behavior management and behavior modification. Is really important to have that background to effective patient counseling and coaching, because what you are trying to do, in essence, is to influence a patient's behavior. And it makes no sense to try to influence a patient's behavior just by providing information, okay? This is really important, this last point. Taking an ecological approach could be more promising than just focusing on this individual patient. And I know that I talked about this a little bit before, but considering the patient's environment is very important, because every patient that we see belongs to a system at home and at work and in the city. And we want to know more about this system or those systems. Do they support what we're trying to do now, or do they do the opposite? Okay, so you want to use an ecological approach. And even for not necessarily lifestyle changes, sometimes it's psychological issues. I often want to know more about the family and how life is like at home for this patient. And sometimes I do intervene with the family members as well. Sometimes I work with the family more than the individual patient themselves, because their influence is extremely important, with patient's consent, of course. These are my references. Oh, I went over time. I am so sorry. I did not pay attention to the time. I'm so sorry.
It's okay. Thank you very much for that wonderful lecture.
Thank you.
Thank you very much. Okay, so moving on to our last but not least speaker for tonight is Ms. Nicole Maftoum, registered clinical dietitian and the founder of Eat Like Nicole. She is also a business and communication dietitian with a weekly presence on Lebanese television and radio stations, sharing tips and recipes throughout her session. And as part of her mission education about healthy eating, she has created a school campaign, Think, Eat, Succeed, visiting more than 50 schools, increasing students' awareness about healthy eating and initiating them to cooking. Also has created the wellness program for employees that she implemented in several corporations. Her passion for cooking enables her to develop healthy recipes for food brands and the HoReCa industry. Thank you very much, Ms. Nicole, for joining us tonight. We are looking forward for your speech or lecture. The floor is yours.
Hello, everyone. Thank you, first of all, for having me. It's really a pleasure to be sharing not only my knowledge, but also my personal opinion and experience about the top trending diet plans. I'm going to share my screen and we shall begin. Okay. So if we take a look back at the way our ancestors used to eat, we really can track, if you want, the evolution of the diet. And this is really very important. It's really very important to look back to see what has been going on, what happened previously, and why we are here today. And we are all familiar with the famous adage and firm believers that we eventually are what we eat and the role nutrition plays in our daily lives. If we do get the proper nutrition, if we manage to eat in a proper way, in a balanced way, exercise as well, and do other things, we will be able to live longer and have less chances of suffering from diseases, suffering from obesity. The way the diet evolved is eventually when, until agriculture was developed, human beings would only get food themselves, either through hunting, gathering, or fishing. And I'm talking about this because this is going to be linked to one of the top trending diet plans nowadays, that is the paleo diet that we will talk about in a while, but that comes from that era where human beings would only eat things they can have access to. It's very important to remember as well something. If you look at cooking, cooking is not only a way to express a certain passion or a way to prepare food at home and eat it. Cooking is obviously what made us today human beings. According to many scientists, the way the human evolved from Homo erectus to an Homo sapien is, if you take a look at the picture, the way his brain became bigger and his jaw became smaller. The jaws became smaller because they required less time to chew cooked food when compared to Homo erectus that would consume more raw food that needed more time to be chewed, and thus the bigger jaw, the smaller brain. So cooking is what made us human beings today. And it's really very important to remember this, because when we apply cooking at home, we have less chances of developing diseases, of suffering from obesity compared to those who eat out more often, and to those who are going to opt for the second thing that happened, that is the Industrial Revolution, whether it be ready-made food products or fast food chains that evolved within the Industrial Revolution, within the evolution of all those things, and that increased the rate of obesity that we have nowadays. It is true that obesity has been present since the Paleolithic times, but nowadays it is at a much higher rate. Is the diet concept new? It's not. If we take a look at the definition of the diet as per Foxcroft, we know that it's a way healthy lifestyle should be included and where we should be eating in a certain balanced way. And actually, the very first dietitian was an English doctor, George Shane. He was tremendously overweight, and he would eat constantly large quantities of rich food and drink. And he began a sort of meatless diet plan, taking only milk and vegetables. And he soon regained his health. And he published a certain pamphlet in 1863, and where he gave the details of what happened to him. So the idea of going on a diet plan and the diet plan idea is not something that is recent. On the contrary, it goes back to this time. And it's also interesting to know that the first popular diet, Banting, it was named after William Banting, so the person who came up with it, and it was a low carbohydrate, low calorie diet. Let's take a look now at nowadays top trending diet plans. We hear a lot about the paleo diet. We know that the paleo is the Paleolithic diet. So if we go back in time, as I previously said, and we look at how our ancestors used to eat, they just used to hunt or fish and get things from the nature. And this is the concept of the Paleolithic diet. So it only encourages the consumption of whole foods that can be available, not bought from a place and not prepared by the food industry. It excludes a lot of food items that we find nowadays in our pantries, in our kitchens, and everywhere around us. What are its cons? If we're going to follow the Paleolithic diet, it's going to be difficult at a certain point in time because we're not going to be able to fully adopt it. Sometimes some things are not going to be available. We will have to replace them with other things that were not available back in the days. And we will be eliminating whole grains that are a great source of fibers. So we won't be eating pulses, we won't be eating a lot of things that are really essential for our bodies. So those are the cons, and this is why it cannot be applied over a prolonged period of time. The keto diet is also another very trending diet nowadays. The idea behind the ketogenic diet, I guess you're all familiar with it, how your body is gonna go into the cycle of ketosis by only selecting foods that are rich in fat, foods that are very low in carbohydrates. You will be entering the cycle. For how long can you be following this diet plan? In my personal opinion, it is not a diet plan that can be sustainable. You cannot be following it for a very prolonged period of time. Carbohydrates are essential. They will not only give us energy, but also are crucial for our bodies. So by abstaining ourselves from consuming carbohydrates for this very prolonged period of time is going to cause many upsetting feelings. We're going to feel a bit depressed. We're going to feel a bit down, and this is not going to be very helpful. And the high amounts of proteins we will be consuming by simply focusing on meat, on all those sources of proteins, may cause within time kidney stones, may cause constipation and other things. And it is definitely not safe for anyone who has certain diseases such as gallbladder or pancreatic diseases, etc. The vegan diet. We know that vegetarians tend to live longer than non-vegetarians, and this is based on many comparative studies that have been done. And this is very true. Vegans, they're going to have lower risks of high blood pressure, high cholesterol, and obesity. And also they're going to have very low rates of type 2 diabetes and certain cancers. It's very good to be opting for a vegan diet. However, we know that other things will be lacking, such as many essential nutrients such as calcium, vitamin D, iron, vitamin B12, and omega-3 fatty acids. Iron that is found in animal sources is going to be different from the one that is found in vegetable sources. So we have we will be having some deficiencies in those essential nutrients that will not maybe help us opt for this vegan diet for the rest of our lives. The vegan diet is also another trending one. It combines the paleo diet and the vegan diet. So it will only consist about 75% plant-based foods, with the remaining being 25% of your nutrition from animal sources. The diet is going to limit processed foods. So this is maybe a better option than to be sticking to the strict vegan diet. The flexitarian diet, it's one of the diet plans that I personally encourage, that I personally follow. Being a flexitarian means that you can occasionally consume red meat, occasionally consume chicken, and rely most of your days on the consumption of vegetables, of pulses, of cheese, of other sources of proteins that could be found in non-direct animal ones. The flexitarian diet has been proven and ranked by the US News and World Report as the #2 and best diets overall. So it's really something that is flexible, because if you're going to be a strict vegan and if you are invited out and they're only, let's say, grilling meat or grilling chicken, or there's a barbecue, you will be tempted, but because of your strict restrictions, you will avoid consuming such foods. But when you are a flexitarian, you will be following a certain discipline. And in case you feel like having this occasionally, you can be having it, and there's absolutely no problem. The flexitarian diet has been proven to help and assist weight loss. So people who eat a vegetarian diet already weigh about 15% less than non-vegetarians. Semi-vegetarians weigh less than non-vegetarian meat eaters. This is according to the Journal of Obesity and Related Metabolic Syndrome. It will also improve your heart health, since you will be focusing more on pulses, on vegetables, and eating less red meat that is very high in saturated fat. It will help you decrease the risk of diabetes, the risk of cancer. We already know that the Institute for Cancer Research always recommends to limit the consumption of red meat, so not more than 500 grams per week. And they noticed that by following the flexitarian diet plan and reducing this consumption, this will also help reduce the number of cancer cases by 30 to 40%. So we will definitely live for a longer period of time, so have a longer life expectancy. In the American Journal of Clinical Nutrition, they found that semi-vegetarians live on average 3.6 years longer than non-vegetarians. So this is also a very important point. The intermittent fasting diet is also another trending diet plan. It's a diet plan that I personally recommend to patients that have difficult working hours or are consultants that travel very often. They travel every week. They don't have a fixed base. They want to follow a certain diet plan, but they do not have control over the food they're going to eat, because most of the times they will have meetings outside the office, over lunch, over dinner, etc. And this is when the intermittent fasting is going to be working properly, because we will be fasting during 16 hours, and during the brackets of 1 to 8 hours, we will be eating. But it's very tricky, because we cannot be eating whatever we feel like eating. We need to stick to a certain diet routine, to health guidelines, in order for us to be able to lose weight properly. And also fasting has been proven as a way that's going to help us shock our body, because we will be following a new, different diet plan. And it's going to help us control diabetes, lower cholesterol, and blood pressure. So prolonged fasting can lead to the regeneration of the cells of your immune system. It will boost your immunity, especially nowadays that we need it. So if someone wants to follow a diet plan and has been trying the same diet plan over and over and over again, and he feels like his body is not being responsive anymore, this is when intermittent fasting can play a major role in helping, shocking the body, helping you lose weight, adopting a different system, and boosting your immunity. The very low-calorie diet is also another trending diet. It's very challenging, because you will be limiting the amount of calories to 800, 900, sometimes 1,000 calories. And this is really very difficult, because you need to be picking the right food items that are going to be loaded in essential vitamins, nutrients, minerals, macronutrients, and micronutrients. And then you can be following this diet plan, but as I said, it's really very challenging. And most of the times when it's followed by patients who do not go to seek help from a professional, they just pick whatever they see in front of them and restrict their intake of calories. They eventually find themselves later on binging and eating a lot of food and having this reverse effect, because they did not focus on the proper foods. So what I personally recommend and what has been working with my patients who want to go on a very low calorie diet plan, meal replacements such as OptiFast can be very efficient. It is already very rich in all the essential minerals, vitamins that are needed. So we will be getting the nutrients. And then what I usually do is that gradually I reintroduce normal food. So they can go on a very low calorie diet for 2 weeks, and then for a week reintroduce proper food, and then the other week go back to another very low calorie week. So this could be working because we will be alternating and we will be controlling the intake of essential nutrients. Now I'm going to talk about the non-diet meal planning, which is what I personally believe in would work with any person that do not want to necessarily stick to a top trending diet plan. So by simply avoiding fried foods that are always going to be very high in calories, and in my opinion, they are empty calories. It's not like we're eating something that's nutritious. On the contrary, it's highly caloric because of the oil and fat content. And it's going to take much more time to be digested. So it's going to upset your digestive system. It's better and preferable to avoid it at all. Salty food, also junk food, definitely not. Everything that's smoked, definitely not. Everything that's processed, we also need to be avoiding it. Focus on water and fiber-rich foods. So whenever we want to eat something or snack on something, it's better to think about an option. Instead of opting for crackers, let's say, we can go for something that's richer in water. So a light chocolate pudding will be healthier because it will contain more water. It will fill us out much more. It's going to be much more satiating. And it's really very important to keep on focusing on proteins in our daily eating plans. So focus on fish, on seafood that are rich in omega-3 fats, and they have the ability to increase the levels of the fullness hormone leptin. If you take a look at the way we should be plating our lunch meal, so we should always start with a salad. 50% has to be filled with salad or vegetables, definitely non-starchy ones. 25% for our lean proteins and 25% for our carbohydrates. Sugar is a very important point we always need to be taking care of. Simple sugars should always be kept as minimum. So what happens? What I noticed with many of my patients, they end up buying products, they don't read the list of ingredients, they think they are healthier, but in reality, they would be consuming a lot of simple sugars, because we know that the food industry gave sugar 56 different names. So someone that's not familiar with that will not understand that a box of, let's say, healthier biscuits will be loaded in sugar, even if it has a marketing labeling as being healthier. So it's always very important to highlight the importance of reading the list of ingredients before consuming them, before buying them. So teaching patients to do that is crucial in order to help them adopt healthier eating habits. It all starts at the supermarket while they are doing their grocery shopping. And the biggest problem, as I said, is simple sugars that are found in many of the products that many people consume. If we are craving for sugar, or if we have patients that tell us we crave every day for treats, for sugary treats, what can we do? Dark chocolate is the best option, and it's about getting used to it, getting used to this bitter taste, but in reality, it's this bitterness that is going to help decrease our appetite and diminish cravings for sweets. Personally, I recommend on a daily basis to my patients that prefer sweet snacks in the afternoon, 30 grams of dark chocolate, and there is absolutely No problem about that. On the contrary, it assists weight loss. And as I said, and as many studies have been done, it helps decrease appetite and cravings for sweet. Also, researchers, they believe that the stearic acid in dark chocolate can help slow digestion, further increasing feelings of fullness. And one study observed that simply smelling 85% dark chocolate decreased both appetite and hunger hormones. So if we have patients that are craving all the time sugary treats and had already their snack, they can simply smell dark chocolate, and this will help decrease their cravings. Exercise is very important and very essential. I exercise on a daily basis, and this is what keeps me sane, first of all, because this hour where I go jog is when I feel that I am much more powerful. Even when we are feeling at our lowest low, the hormones that our body is going to secrete are going to help us feel naturally very happy. And this is a way for us to balance in between the calorie intake and how much calories we are burning. So it's really very crucial to be exercising and to be including this. Getting enough sleep is another important point that you already discussed and that I'm going to highlight as well. So all the studies that have been done, they show that when we get less than 7 hours of sleep per night, this is going to affect our appetite. We're going to feel hungrier the next day, and we will reach out for sugary treats, for things we weren't necessarily needing or our body didn't really need, but to compensate this energy that we didn't get during our 7 hours of sleep, we will be compensating it by eating other things. So it's important to get enough sleep. Now, procrastination is a technique that really works. So let's say a patient is craving for another 60 grams of dark chocolate or another treat or to serve another serving. The idea of procrastinating, according to some researchers, so picturing yourself indulging in the food you crave and not reaching out for it on the spot, it may actually decrease your desire to eat them later on. So this really works. When you say, I'm going to have it in 2 hours, and then in 2 hours you say, I'm going to keep it for tomorrow, it sort of works. And in one experiment, 51 participants, they first imagined eating either 3 or 33 candies before being given access to a bowl of the candy. Those who imagined eating more ate 60% less of the candy. So it's really very important to use your imagination, to let the patients use their imagination, because it's all in our head at the end of the day. So if you just imagine that we had it, we can convince ourselves. And it's always good to remember, why did I talk about simple sugars? Because excessive intake of sugar is gonna lead to all those things that have been listed in this infographic and that doctors previously were talking about, whether it be the insulin resistance or all the other metabolic disorders, diabetes, and the increased rate of obesity because of those simple sugars that are found everywhere. So even fructose, that is a natural sugar found in fruits, and this is one of the biggest problems I face with many of the patients that come to see me at my clinic for the first time, and they tell me, I eat in a very healthy way. I have around 5 to 6 portions of fruits per day. But fruits are rich in fructose, and an excessive intake of fructose is gonna lead to many problems. So first of all, we will be suffering from insulin resistance, leptin resistance, and it's going to raise levels of triglycerides. So it's really very important to be monitoring not only our fructose intake, but our simple sugar intake that is found nowadays in 80% of the products we find at the supermarket. So eating natural foods, reading the list of ingredients before picking any item, getting inspired from the Paleolithic diet plan that relies on natural foods, that relies on everything that's not processed, is very important. And carbohydrates, in my personal opinion, yes, it is important to have a certain percentage of carbohydrates per day, but carbs are addictive. So the best way to resist carbs is to focus on this list of super swapping things that are addictive in our eating plans, instead of opting for noodles, to be preparing zoodles at home, to be recommending that to our patients, even those who love spaghetti, for example. It's about habits, and it's about mixing 50% zoodles at first, or 70% zoodles with 30% noodles, and then decreasing the percentage, and then getting used to the freshness, the crispness of vegetables, the fact that they contain more fiber, more water, and that will fill us for a longer period of time. When compared to carbs that are simply addictive, they do not contain much nutrients. When we talk about white rice, white noodles, when we talk about tortilla wraps, for example, quinoa, many think that quinoa is like the superpower, very rich in antioxidants, and it helps us lose weight. I have a lot of patients who come the first time and tell me, I have a quinoa salad for dinner every night. And then when I ask about the quantity, they just tell me a large bowl of quinoa. And then when I tell them, do you really know what quinoa is? Quinoa is in reality rich in carbohydrates, but it's the only source of it's the highest source of vegetable of proteins coming from a vegetable source. So this is what made quinoa different from other things. But that doesn't mean if you will be consuming quinoa, you will be losing weight. On the contrary, you will be ingesting a lot of calories. So it's important to be doing those super swaps. I use a lot of pulses in my recipes, whether it be savory or sweet. So instead of preparing brownies with flour, I use red beans, mix them with dark chocolate with a bit of brown sugar, and the taste is really delicious. And a piece of red beans brownies is going to be loaded in proteins and fiber when compared to a piece of regular brownies that's going to be made using flour, white flour. Even if we're going to use whole wheat flour, it will have a bit more fiber, vitamins, minerals. But if we compare it to the one that we prepared with red beans, the one with red beans will have much more fiber. So our focus should always be towards those foods that are going to be rich in fiber, rich in proteins, and will have many more nutrients to offer as superfoods when compared to other ones that will not have all those nutrients. Finally, I'm a strong believer in the laughter therapy. I'm a strong believer in the fact that everything starts here. Today, if anyone wants to lose weight or wants to be healthier, he should start by feeling happier and feeling better about himself and motivating himself in order for him or her to be traveling through this healthier journey and reducing weight and being far from the obesity ranking. So we should always surround ourselves with people that are happy. We should adopt the laughter therapy. Try to reduce stress as much as possible. Whenever we stress, our body's gonna release a hormone that's known as cortisol. Cortisol is gonna increase the deposits of fat around the abdomen, and it's gonna increase our appetite. So it's really very important to be reducing, managing stress, trying to opt for things that make us happier, exercising or opting for hobbies or surrounding ourselves with people that make us happier. And to remember that 15 minutes of continuous laughter will help you eventually burn more calories. So try to be always in a positive mood and try to reduce as much as possible negativity around you. Those are the references that have been used. And finally, always remember to count the memories, not the calories. So Don't be obsessed, and don't let any patient be obsessed about calorie counting. It's a healthier lifestyle modification. It's not a one-stop, it's a journey. So there's no one top trending diet plan that is 100%, that's going to guarantee 100% weight loss. As you noticed, if we mix and get inspired from here, apply this from here, and adopt general guidelines for healthier lifestyles, we will live for a longer period of time and be happier.
Thank you very much. Thank you very much, Dr. Nicole. That was a very interesting presentation, and all of the presentations were quite informative and interesting. I'm sure our attendees and guests agree with that. So our last 10 minutes or so, we will be going through the questions. We have a few questions coming up in the Q&A box. If you have any more questions, please feel free to type your questions, and we will be going through them right now. Okay, so let's not waste more time. Our first question from Dr. Muhammad Idris: what is the nervous system and hormonal regulations with specific amino acid and high protein diet? It's not being sent for a specific speaker. If anyone wants to answer that question.
Shall I go through it?
Yes, please.
So basically, dietary proteins and amino acids, like including glutamate, generate the signals involved in the control of the gastric and intestinal motility and pancreatic secretions and the food intake. They would include like postprandial meat-induced visceral and metabolic signals and its associated nutrients, the amino acids and glucose. The protein reduces the gastric motility and it stimulates the pancreatic secretions. So the protein and amino acids are also more potent than the carbohydrates and the fat in inducing short-term satiety. And so the high protein diets, they lead to the activations of the neural pathway in the brain stems, and then it actually activates the satiety.
Thank you very much.
Thank you.
Yeah, I think that answered the question. Okay. Next question from Dr. Yvonne. What are your experiences on intermittent fasting and keto diet? And again, anyone is free to answer that.
So,
yes, please.
Yeah, so as I said, intermittent fasting works because fasting has been proven. When you shock your body and you do this fasting, you change the way you usually eat. It really helps you. It's very healthy. We know that from the special during the holy month of Ramadan, when we fast. This is very healthy for us. It's a way to detox our body. It's a way to restart our system. So intermittent fasting works in the same way. We have this bracket where we can be eating. And the most important thing is to be eating properly during those 8 hours, not to be eating unhealthy food items and then say this was not helpful. So to be focusing on healthy foods, to be having several 3 to 4 meals, and to be exercising, to be living in a stress-free environment, and this will really work. And as for the keto diet, there's absolutely no problem to opt for the keto diet for a week or 2 or 3, but it's not sustainable. We cannot, in my personal opinion, and as I've previously seen with my patients, many got fed up of continuing it for more than 3 weeks because, as I said, your body will be lacking carbohydrates. You will feel sort of tired all the time, and as studies have shown that an excessive intake of proteins and an excessive intake of fat from those type of proteins, so from animal sources, the saturated fat is also going to increase, like somehow, the bad levels of cholesterol. So it's not a diet plan that I can tell you go ahead and go and adopt it for the rest of your life or for the next upcoming 2 months. But you can be opting for this diet plan for 2 weeks, 3 weeks, and then you continue with a balanced eating plan.
Thank you for that. Next question for Dr. Khadija. Most of the obese, where was the question? Yeah, in the first assessment for obese patients with insulin resistant, did the diabetes medication help, or has it been helpful?
Oh, well, what we have found in our clinic is most of the patients who come to the obesity clinic are pre-diabetics. You'll find that their A1C level is in the pre-diabetic range. We do put them on metformin, which is helps to reduce the insulin resistance as well, and it does help them. And one of the famous drugs which are now recommended and people are asking for it, and it is FDA approved, is semaglutide. And these patients really do well. Of course, some of them don't tolerate GLP-1s, but yes, it's very effective. And it brings them back from pre-diabetic range to the normal range. Yes, you can use them.
Okay, thank you for that. Next question is, a patient with hyperthyroidism and have difficulty losing weight, what are the appropriate diets for them in helping them obtain weight loss? Anyone is free to answer that question.
Yeah, first of all, let me tell you, it is not hyperthyroidism, it must be hypo. Because hyperthyroid patients are usually very thin because they have got a very high BMR. And so I think it was a mistake. But about the diet part, we do not recommend anything special, but maybe the dietitians have something in their mind.
Does anyone would like to answer that from the dietitians?
I don't think there's anything special.
Most probably, yes. Yes, exactly. Yeah. Okay, the next question is for Dr. Najat. Is there a valid test to measure a patient's motivation level to change?
There are instruments out there that measure motivation, measures that assess the concepts that are termed self-confidence, self-efficacy, and if you have a patient, I'm not sure if there are some that can be used in an outside psychology perspective. I'm sure there's something out there, but they are standardized and tests with good psychometric properties out there. But, those tests and assessment tools should not replace your own clinical judgment and how you interview your patient and your own assessment of them. So you can use them in combination. Even for us psychologists, when we use instruments, we use them as part of a comprehensive evaluation that also includes an interview and our own clinical assessment of the patient.
Okay, another question for you also, Dr. Najat. What is the most effective strategy to change school children nutritional behavior, in a sense?
That will depend on if a patient comes to me and they say, my child is only eating cookies and milk, for example, and they will not eat anything else. There are behavioral interventions for introducing different food items. And I'm sure the dietitians on the panel can also add their bit to it. But from a behavioral perspective, you definitely want your child to have a balanced diet. And there are behavioral interventions to assist parents in shaping the child's behavior so that they are more likely to accept or even try newer food items. Some kids are extremely picky eaters that I used to see in our clinic back then when I worked outside this country, who come with what is usually typically diagnosed as a feeding disorder. A child who's extremely picky, they will just eat 1 or 2 types of food, and they cannot even tolerate the texture of certain food types. And of course, they come to the clinic after they have been assessed and tested, and they are lacking in so many nutrients. And usually the treatment in our clinic as psychologists is behavioral, in collaboration with pediatricians as well, to make sure that this child is getting what they need. And usually the general advice to parents is to be patient, because it takes at least maybe 15 times when you introduce a food type to a child for them to just try it, let alone accept it or like it. And sometimes parents are discouraged that their child will only eat, for example, pizza or indomie or whatever, so that they don't cook much anymore, because they say the child is not going to eat it. And actually, by doing that, they are reinforcing this picky eating or narrow food dietary habits. So yeah, they are behavioral interventions. And depending on the severity of the case, the intervention is designed.
Thank you. Thank you.
Sure.
Can I add something? I totally agree with you, doctor. And this is as well known as food neophobia. It's the the fear of introducing new foods that many kids suffer from. And this is one of the reasons for which I created my school campaign that I applied in several schools, and where I would go as an outsider. Students will not know that I am the dietitian. So they would know that I'm there to actually tell them more about food, tell them what's better for them, what's healthier for them. And what I noticed is when we cook in front of kids, because that's what I do at school. So I prepare za'atar pancakes as a substitute to manouche. In order to reduce food leftovers, I ask kids to bring leftovers they have at home, such as lubia bzeit or mjaddara, and I turn them with them during the culinary workshop into pancakes, for example. This is when they start getting more interested in trying different things, and they go back home telling their parents, there's this outsider that came today, taught us how to do this, how to do that, and told us that this is important, etc. And I would have the parents contacting me later on to thank me, because they have been trying, and they, even if they took kids to see a dietitian, because the kid knows that he's going to a clinic or to a doctor, this sort of freaks him out and doesn't really work for him. So an outsider's intervention in a funny, in a different way, in a creative way, through cooking, my personal experience, helps kids try accepting new food items. And as you said, cooking at home is very important, and doing games with kids, blind tasting, or even teasing your kid, telling him, I prepared this for me, but I'm not going to let you taste it. He would then want to try new foods. And
yes.
As you said, doctor, like sticking and repeating this up to 15, 20, never giving up is what's going to eventually work out.
Great job, Nicole. It's really wonderful.
If I may just add to what Nicole just mentioned, also kids, they learn from their parents, and this applies to different behaviors, including dietary habits as well. And when a child eats, the family meal is so important, especially for the picky eater, because they get to sit with the family at the table, and they see the rest of the family, or maybe the parents, enjoy a food item that the child is not liking yet, but they see them eating it and enjoying it. And kids learn by our behavior more than by what we tell them. True. So sometimes picky eaters, they just eat alone, and that maintains picky eating, actually.
True. And
yes,
I believe in my in the way my mother, my grandmother, and the way we have all been raised. No television while eating. Nowadays, they must have their iPads in front of them. They don't communicate when they're sitting around the table. They just go sit in their corner, have their usual food while watching something, which is really very bad in my opinion.
And one last comment, if you guys allow me, which is from a behavioral perspective, having healthy food accessible at home. So I usually advise my patients, you have this coffee table and you have all these chocolates, and maybe sometimes they are nuts, but they're covered with caramel and with chocolate and with all these additives. If you put healthy snacks on that same coffee table and kids have access to those, it's better than if they have to go look for it, because kids eat what's available, what's around them. We are not born, like, correct me if I'm wrong, our expert nutritionist here, but a lot of what we eat is acquired. And if you surround your kids from an early age with healthy food items, they will start to like them, and they will start to acquire the taste and like it, and it's going to be sustainable than it's something that's foreign to them. I've seen kids who were brought to our clinic a long time ago, like I said, who would gag if they put a piece of orange in their mouth because they just cannot stand the texture. So just familiarize them and having easy access to healthy food is very helpful as well.
True, very true. And even when you open the fridge, because kids can only see, like, let's say the first shelf or the second shelf.
That's true, yes.
With colorful vegetables that you cut with a healthy dip so that they can reach out to that, instead of opting for something else that's not going to be healthy or that's going to be fattening without essential
It's a wonderful strategy to encourage healthy habits at a very young age, and that's how you can keep the children much familiarize themselves with the healthy foods. Exactly. Okay, so we have time for just one more question before we wrap up. Do you think a keto diet can be a solution for insulin resistance? If anyone is likely to answer that. Dr. Ms. Nicole?
It could be, for then again, if that person is going to follow that diet for the first 2 weeks, 3 weeks, and then gradually reintroduce complex carbs in minimum amounts and watch out everything they're eating, this would be helpful.
Okay.
But it's not like the solution to the rest of their lives.
Exactly.
Absolutely.
Keto diet. No.
I agree with Nicole. Yeah, absolutely.
Exactly. Okay. So I think we have not more time to take any more questions, although we have, mashallah, a lot of questions coming in. So finally, I would like to thank our wonderful speakers for this excellent lectures that we have today. It was very interesting. And I would like to thank you all one by one. Thank you for attending. Thank you for being with us tonight. And we hope to see you again in our future webinars, and CMEs will be available in 14 days after you fill out the evaluation, which will be sent to you via the registered email ID that has been registered. And I would just like to remind you of our future upcoming webinars organized by the Emirates Clinical Nutrition Society. Our next coming webinar will be on the 13th of July on bariatrics and long-term complication. And then we have a webinar on the 11th of August, which will be about tube feeding and wound care management. 15th of September about diabetes and weight loss management. And 29th of September about cow milk protein allergy. These will be our upcoming webinars. And I hope you had a wonderful time with us. Thank you again and have a good night.
Thank you very much.
Thank you very much.
Thank you so much.
Thank you.
Thank you very much, our wonderful speakers for tonight. Thank you.
Thank you.
So much.